Yes.
Okay. So, good morning, everybody. Thank you for coming today. This is my second time here. Such a pleasure again. Today, we're going to talk about a recent case that happened in my hospital. This was a penetrating neck injury. It's important to remember that this kind of injury is quite common in the urgence. It constitutes 5 to 10% of the trauma that will arrive in your hospital. So it's important to know how to treat and how to manage this complex area of the body. All right, so this is a case. This is a 48-year-old male, victim of attempted murder. He had a gunshot wound in the right side of the neck when he arrived to us. He had a stab wound in the back on the left, as you can see in the image. These stabs were between the scapular and the midline, and he had multiple stab wounds in the upper limbs, like he was trying to defend himself in the time of the attack. We don't have exactly the time between the accident and the transport to the hospital, but we knew that at the arrival, the patient was hemodynamically stable. He was verbalizing and complaining pain in the neck, in the back, and a mild dyspnea. This is the cervical trauma. The entrance was a 1 centimeter diameter injury at the cervical zone 2, right in the neck. There wasn't an exit hole. So basically the bullets were in the body between any kind of the neck and any part of the neck. We didn't know. And we couldn't note an active bleeding. There wasn't an expanded hematoma. All movements were preserved, so the cervical maybe without any injury. We did a first lab test with 11 hemoglobin and RNI normal. So basically, we had a patient stable without any complex founds in the neck, verbalizing, with mild dyspneic, and this was our situation. Now it's open for the audience.
Dr. Ontrak, any comments?
Certainly. So another interesting case, and in this case, I would do. Usually, I always start with the physical exam, including the ultrasound. So I do an EFAS, look for evidence of loss of sliding on the left side, and if so, I would put a chest tube in, or you can just go straight to a chest X-ray, including the neck, so you can see where, if and where the metal is in the neck, where the bullet is. And based on your examination, there's no expanding hematoma, there are no hard signs. I take it there's no evidence of crepitance anywhere. So based on the lack of hard signs, I think it's reasonable to do the X-ray, rule in or rule out a pneumothorax, put a chest tube in if there's a pneumothorax, and then you can proceed to do a CT, a CTA of the neck. And if you can be right there, and if you're able to intubate him, if he develops trouble with the airway in CT, then I think it's okay not to intubate him before the CT scan, given that he's stable and there are no signs of stridor or other airway compromise. In addition, you do all the other things, 2 IVs and general examination, dress the wounds on the extremities and on the back.
Any other comments, Dr. Kasim?
Good morning. Can you hear me?
Yes, we hear you.
Oh, good. So the man who has the most experience in this type of injury is Dr. Dimitri Dimitriadis, who originally worked in Johannesburg in South Africa, and then he was appointed professor of surgery at UC California, Southern California. And he wrote a very provocative paper years ago, many years ago, because in South Africa, this type of injury is extremely very common. But in United States, when Dr. Kinsey Inaba analyzed this type of injury in United States, not many surgeons see more than 1 to 2 cases a year. So it is not very common in one surgical career. You might see maybe 3 or 4 cases. That is lucky if you're like if you work in a big trauma center. But most surgeons have 1 or 2 cases they have dealt with. Be that may, what the protocol that I have learned from Dr. Dimitriadis is that this is one case where you do a thorough, good physical examination. In other words, you record everything, and starting with the phonation, the voice. If the voice is intact, it is assumed that the tracheal airway is intact, and then look for any external signs of bleeding which should come before the voice, and also and look for any bubbling through the wound, and that might indicate that the patient may have a hollow viscous injury. And of course, you have to document if the patient has any neurological deficit, and also measure bilateral blood pressures to make sure that they are equal and there is no discrepancy there. Having done all that, and if the patient is awake and stable, the single most important test that he recommends is a CT scan. And in order to send the patient to the CT scanner, he must be absolutely stable and his airway must be perfectly intact. Otherwise, you will have a big drama in the CT scan. So this patient, he looks very, very stable. Record everything that I have just mentioned. And I think I would send him to the CT scanner. And there I can ascertain, and also CTA at the same time, I can ascertain not only the vascular injury, sometimes even esophageal injury can be detected. And also you can look at the cervical spine to see if there's any injury to the cervical spine. So you get all these 3 important vital structures in one test. And that's what I would do. Thank you.
Thank you, Dr. Kasim. Dr. Barros, you want to go ahead and continue?
Yes, Dr. Flavia Ramos going to say something. She's my staff in the residence. Maybe some important information.
Absolutely.
Flavia?
Hello, good morning. I just wanted to ask Dr. Ontrex and Dr. Kasim a question. Would you both intubate this patient after the CT to protect the airway?
Do you want to go first?
You go ahead, Dr. Kuntrak.
Sorry?
Go ahead, Dr. Kuntrak.
Yeah, well, after would I intubate after the CT? Well, that depends on what you find. So if you don't think that he needs to be intubated now and you're there with him, if he's talking and he's not, there's no stridor, his voice sounds normal, and he's just complaining of a little shortness of breath that you can explain perhaps with some splinting due to a pneumothorax, you need to take care of that and see how he looks. But if he doesn't, depending on your situation, if you If his voice sounds normal, you really have no reason to be concerned with the airway, and you can attend to him in the CT scanner in case something bad happens, in case his condition changes, either you or an anesthetist or somebody. Then I wouldn't intubate him in advance. That's just based on what I heard without seeing him. And then based on what you find, you can decide if you need to take him to the OR, and he's stable enough, you can intubate him there. If there's a question, you need to do upper endoscopy to look at the hypopharynx and the esophagus. You might want to do that intubated. So it depends on what you find.
I totally agree with Dr. Untrat. There are certain indications for intubating a patient like this. He must have signs of airway obstruction, or he must have some changes in his phonation, his voice. He must have crepitus. If there's any crepitus, then you'll be suspicious. And he must have expanding hematomas somewhere that you're determining from the physical examination. All these are signs that you may have airway compromise when he goes to CT scanner or even after the CT scanner. If any of these signs are present, then it will be wise to intubate. But once you intubate the patient, then you lose control of other faculties, such as he cannot tell you what he's feeling, and he's paralyzed. So I would not intubate this particular patient at this time before CT scanner. And then after the CT scanner, I need to look at the films. Thank you.
Thank you.
Go ahead, Dr. Barros.
Okay, let's move on. So what we did, we took him to the CT scan room and we decided to do a CT scan. Basically, it's very near from it's near from the trauma bay. And let's see the images and what we had. There is another one that I'm showing next. Here is a cervical CT scan. We can see already a tremendous emphysema, but basically only this in this series. The other one is right here. The cervical spine and the column was intact. We can see right now the bullet between the scapular and the thoracic wall. A hemothorax in the left thorax. And unfortunately, at this time, we didn't have contrast, but we could see that there wasn't a big hematoma or any sign of vascular trauma, but without the contrast, it's impossible to say that is absolutely without any kind of vascular trauma. But we had no cervical fractures. We had a tremendous soft tissue emphysema and a left hemothorax and a contusion in the left parenchyma. We didn't intubate him at this time because he was stable, verbalizing, and his voice was quite normal. but we put him a chest tube and took him to the operative room to explore. This was our chosen cervicotomy. We did a right cervicotomy, basically passing close to the entrance hole of the bullet and extended to a kosher incision. This is the cervical aspect after cleaning up the mass. And what we found was that we had the main vessels intact, the right thyroid gland had been damaged, the recurrent nerve had been damaged, and it was ligated. And we have an esophagus trauma at the anterior wall and in the posterior wall as well. The airway was intact. And here you can see at the sternocleidomastoid, the penetration tract of the bullet. This is a video to show you more dynamically what really happened. Incision, the bullet tract, this is the right lobe of the thyroid already resected, the nerve ligated. And they're going to show you the injury in the esophagus. There is another video with the esophagus already desiccated from the tissues around him. This is the second video, only with the injury of the esophagus. In one hand, you can see the posterior injury here. The posterior injury. And the anterior right here. So what a mess. And I'd like to know from you all how to manage this kind of trauma at the esophagus.
Dr. On track.
Well, that's quite interesting. First of all, I would say that part of your evaluation during your physical exam, probably would have been obvious that the chest tube was needed on the left side before going to CT. I think that it worked out okay, but that's something you'd want to know about ahead of time. And so if you listen to the lungs, there'd be no breath sounds, reduced breath sounds on that side. I would have done the EFAST, and although a chest X-ray would have shown it also, but with the EFAST, that you wouldn't have seen sliding on the left, you would have seen it on the right. And then also when you do the rest of the FAST exam, when you look at the left side, the spleen and the diaphragm, you would see that the vertebral column, you should only be able to see echoes from it below the diaphragm. As soon as you move above, because the air in the lung blocks the sound waves from hitting the spine. In this case, you have blood instead of the aerated lung tissue between the chest wall and the spinal column. So you would see a continuation. So you would have known right away he needs a chest tube. You put a chest tube in, and then you would have seen the bullet by the scapula. So it seems that that what was initially thought to be a stab wound in the back, was that the exit wound of the bullet, or was it a separate stab?
Yes, perfectly. He was backstabbed, and what
was
we,
another injury.
Yes.
Another injury.
Oh,
He
another
was
injury.
stabbed,
So the,
and
so
yeah, he was stabbed and he had a gunshot wound.
Yes,
and the bullet happened to go in the same area on the left side. Is that right?
correctly.
Yeah, down through the across the neck, through the esophagus. Okay. Anyway, so what to do in this case? I think so. The injuries, the digestive injury is in the upper esophagus, actually distal to the cricopharyngeus muscle, from what I gather. And it looks like there's no contamination. Everything's very clean, and it's reasonable to go ahead and repair them primarily. You can wrap the omohyoid muscle or strap muscle around it. It's probably not necessary, but because there's not a lot of loss of tissue. But I would go ahead and do a repair, and whether you need to have a nasogastric tube. I mean, maybe I probably, I don't know whether I put one. I'd probably be safe and put one in while you're there, so you can guide it across the area of the injury. And as far as the recurrent laryngeal nerve, you like it, I guess that's okay. And if you have one cord that's not paralyzed, he shouldn't have any problems. His voice will be a little different, although you didn't. I guess he would have had a little bit of hoarseness that sounded normal to you, but I suppose that's okay. I don't know if anyone that actually tries to repair the nerve, I don't recall from my days years ago with the thyroid expert we worked with. Occasionally, he's cut the nerve a few times. I forget whether he repaired them or not, but I think what you did was okay. I think the only thing I would have done differently is realize the need for the chest tube first and do that. Chest X-ray or ultrasound, and then before going to the CT and then the OR.
Dr. Kasim, any comments?
Before I make a comment, I saw Dr. Supra joining us as well. He's an expert surgeon from Bangkok. You might want to ask him some questions as well. I don't know whether he's joining us on this meeting or not.
There he is.
Dr. Supra?
Good morning. Good morning. Can you hear me?
Yes, we hear you. Thank you.
There you are.
I agree. I agree with Dr. Untrash's approach, surgical approach for this patient. I think that the best option for him at this point is to try to do the primary repair after you debride the devitalized tissue. And you have two options. After the repair, you can pass the NG across the injury for distal feeding route, or you can either perform the repair over the T-tube to drain the saliva out, and you do another feeding route distally, like gastrostomy tube. And I agree with buttressing the repair with a viable muscle at the neck. And after everything we have done, we have to put the drain. I usually prefer Penrose drain to make it a controlled saliva fistula if the leakage occurs. And in extreme cases, if you cannot do the primary repair of the injury, you may think about cervical esophagostomy and distal feeding route. Thank you very much.
Dr. Barros, you want to continue?
All right, thank you all for the comments.
I'm welcome.
Could I
I'm
make
just
a
going to make
comment now?
one.
Go
Sorry.
ahead, Dr. Kasim. I'm sorry.
Okay. So you see, Dr. Supra had some words of wisdom there. So I agree with Dr. Kuntrak and Dr. Supra how to manage this. There are a couple of points in managing a bullet wound to the esophagus, which is quite different from a stab wound to the esophagus. When you have a bullet wound, it is a cavitational injury, and the magnitude of the injury is much bigger than a simple AP anterior stab wound. Be aware of that. What you do with the stab wound is entirely different from what you do with a bullet wound. Having determined that thyroid is injured, you removed it, fine, and you have identified the recurrent laryngeal nerve injury, you documented, and like Dr. Untrak said, I have not heard of many surgeons trying to repair that because the nerve is so small, and usually it is sacrificed. Now comes the esophagus. You need to get very good control of the esophagus above and below the injury and identify the extent of the injury by having an endotracheal tube into the esophagus, blowing air or blowing some liquid to see exactly where the holes are so that you know exactly how you're going to repair this. The master surgeons who do repairs of the esophagus, they are extremely meticulous. And I used to work with a surgeon in London, England. His name was Dr. Brain, and he really had a lot of brain, and he only did esophageal surgery. And he taught me that in a bullet wound to the esophagus, you try to do a double layer repair, and the upper layer should be interlocking after every 3 stitches. Whether you employ what Dr. Supra has suggested, which is almost like a T-tube. You know, you put a big T-tube in and then bring the limb out at the control fistula. He didn't do that. And he put an NG tube down and did a meticulous repair using 4O. And then he taught me not to encircle the esophagus with the omohyoid or any other strap muscle, because the possibility of that strap muscle dying and giving subsequent stricture, etc., in that area is consequential. And he says the better idea is one is to buttress, like Dr. Supra has mentioned, meticulously over the repair, and then test it afterward to make sure it is leak proof, and then leave the NG tube in place. And then following that, put a controlled drainage, either a hemovac, flat hemovac, or a Penrose drain. So if you do have a repair, it becomes a controlled fistula. And of course, appropriate antibiotic therapy to this area is mandatory. Thank you.
Dr. Ramos, any questions or comments?
Just one comment. Our ultrasound machine is broken, so that's why we didn't do a fast exam. And as amazing as it may sound, it's faster to get the patient to the CT scan than do an X-ray. Way faster.
Okay. Go ahead, Dr. Barros. Continue, please.
Thank you. So as Dr. Untracked said, the patient had a hoarsened voice, but we thought it was normal. And it was already a sign of the nerve injury. And what we did, sorry, go back, all right. So we did a rhinolobectomy of the thyroid gland. We closed the esophagus with a double layer suture, and we used a nasogastric tube to mold it and try to do the repair. We used a Vicro 3O in the first layer and the second layer with Prolene, all simple knots. We started amoxicillin plus clavulanic acid, and we did drainage with the Penrose, as you can see. And this is the final aspect after the repair. The first day after the surgery, in the intensive care unit, the patient was already extubated. There was no vasopressors, normal vital signs. We did an X-ray, as you can see, quite good. The parenchyma expanded, no pleural effusion. The blood gas test was okay. The thoracic drain We had 400 milliliters of cytomatic fluid in 24 hours after. In the second day, we started with a good day. We had already some signs of complication. We were able to see a cellular leak through the cervicotomy and through the drain. The wound became hyperamid and it had some swelling in the borders. The patient started being dyspneic, requiring oxygen mask. He became febrile, the vital signs a little worsening with 132 heart rate, saturation quite normal but with the oxygen mask, and a normal blood pressure. And we became very concerned about mediastinitis, and another group started thinking to manage this conservativity, but we were gonna tell you what we did before the discussion. At this time, what would you do? A second day surgery with a red cellular leak and signs of inflammation in the wound, and the patient a little bit unstable. What would you do?
Dr. Supra?
Yes, at this point, I agree that the patient is having mediastinitis and sepsis. So the only option you can do is to bring him back to the OR and re-explore the neck wound and wash everything out of the neck and the mediastinum. You can clean the upper mediastinum through the neck wound. And if the repair fails, I may have performed the surgical esophagostomy, the end surgical esophagostomy at this point, and I will close the distal stump, and I will perform the distal feeding route with gastrostomy. Thank you very much.
Thank you, Dr. Ontrak. Dr. Ontrak, can you hear me?
Yeah, yes, I can. Yes. You know, I agree with that. It's quite ill. And, you know, I think I agree everything Dr. Supra said. I really have nothing to add beyond what Dr. Supra mentioned.
Thank you, Dr. Kasim. Any additional comments?
Everything Dr. Supra said is the right thing to do, in my opinion. Plus, you must have adequate antibiotic coverage and make sure that you are using broad spectrum antibiotic and you're giving the right amount, the right time, the right dose, and all that sort of thing. Now, if you do find that you have necrosis in this area, which is unlikely because it's only 24 to 48 hours after the surgery, and then you may be tempted to do what Dr. Supra mentioned, which is staple and the esophagus and convert it into a blind pouch, and then do a feeding gastrostomy and wait for another day to reconstruction. And in the meantime, you have to do an adequate drainage of the mediastinum. If you don't drain that, the suppuration will go on and you will lose the patient. And you have to be extremely brave and to go ahead and open up wherever you want to open up to drain the mediastinum, because the pus in the mediastinum is going to kill this patient. Thank you.
Thank you. Dr. Ramos, any comments?
No, no comments.
Okay. Go ahead. You could continue, Dr. Barros.
Okay. So what we found, We found a fistula at the posterior repair of the esophagus with a salivary leak at the distal third of the suture. The anterior suture was okay, and there was plenty of dead tissues and with a fibrinous aspect and necrosis. But this fistula wasn't pouring out saliva wasn't plenty of saliva, just a little small knot of the suture. We thought this febrile was due to necrosis and inflammatory response after trauma. And we did debridement of this dead tissue. We did esophagostomy utilizing the anterior wall that was already been damaged. We did a loop esophagostomy, but in the other side, in the left, in a clean area. We did a gastrostomy for start the food as soon as possible. And we closed with another Penrose drain. And that's what we did. Well, 4 days after this surgery, this is the aspects of the neck of the patient. The Penrose drain is with a secretion, but quite normal. There wasn't any more kind of infection or worsening of the ill. The esophagostomy was quite okay. The patient were advised to speed the saliva. He had no complaints at this time. He was eupneic, had normal vital signs. The lab test quite okay. The reactive C protein in 10, the lower value until now, no leukocytosis. So we removed in the 4th day these drains, and we started thinking about do a methylene blue test. And in the 8th day, we gave him the methylene blue. This is what happened. So at this time, we contact the thoracic surgeons, and they recommended us to do a new CT scan due to the stability of the patient and what had already been done in this neck. So we could, sorry. All right, so in this time, would you do what the thoracic surgeons recommended, or anyone could explore the neck again?
Dr. Kasim?
I don't think you need another CT scan because it is obvious that the anastomosis is leaking, and we all know what happens to a patient who has a leaking anastomosis in the neck. It'll go straight into the mediastinum and he's going to die if you don't do something about it. I think CT scan is not going to really add anything to your armamentarium. The patient needs to go to the operating room. Now you need to be really brave to be able to take care of this patient and do an extensive procedure, which is remove the part of the esophagus that has been injured and staple above and below and do a feeding gastrostomy and effective drainage of the mediastinum so that you don't have any more leakage into the cavity of the chest or in the mediastinum to get the patient on the road to recovery. Thank you.
Dr. Supa, any comments?
I agree with Dr. Kasim. Thank you.
Dr. Ontrack.
Yeah, that's certainly reasonable. Although, you know, in this case, the methylene blue is coming right out the incision. Although you don't know if all of it's coming out, some of it's going down, but the patient is stable, and you know, even if your first option, your first choice would be to go back to the OR, and then you ask an esophageal surgeon, he says, well, we do the CT. because you still have the 10 minutes to do the CT, but I would give him the oral contrast and see where it's leaking through, or the source, to get a better idea about what's going on before you go back to the OR. I think that's also reasonable. But I think either is okay in this case.
Anyone else would like to comment?
Just one comment. The second surgery was performed by our thoracic surgeon.
Thank you. Dr. Barros?
Yes, that what Dr. Antract said. This is what I would ask you. If I have at this time contrast and had given orally, would you wait for the CT scan or not? But his comments already answered, and that's exactly what we did. We did a CT scan with oral contrast. It's been past 8 days after the second surgery. The patient was stable, so we had time to do this exam. And what we found is that the oral contrast is in the stomach, as he had swallowed, and in the neck, another time here, we can see that this escaped through the cervicotomy, but no contrast is found in the mediastinum. We decided to give another chance to this patient with no operative approach. And the follow-up, after 20 days, this patient was discharged home with this final aspect of the incision already cleaned and still with the salivary leak, but the aspect was good. The patient was well oriented, and 1 week later, actually last week, July 10th, he came to us as an outpatient, and we did another CT scan of the neck. At this time, there isn't any more salivary leak, and we decided to start oral food intake with liquid, and the patient is very well, and we will see him in 2 weeks. Any comments of the management? About the management?
Dr. Supa?
Thank you, Dr. Ramos, for presenting this case. Your excellent management and your good outcome is very appreciated. Thank you very much. Thank you very much.
Dr. Kasim?
Do you know what they say? That surgery is partly science, partly art. If you apply science to this shouldn't have happened. But if you apply art to surgery, this is a sort of lucky thing that happens to the patient. He gets away without a big, massive surgery, also esophagectomy, and then subsequent, one of those Ivor Lewis type of operation where you have to pull the stomach back to the neck and do an anastomosis. Horrendous surgery. And here, you just wait it out and the patient got better. Sometimes it is good to be lucky than good. Thank you.
Dr. Ontrak?
Yes, so very, very nice case. Very well managed. And, the mediastinum on the CT was no evidence that it was infected. And I guess it could have been because the bullet had to go down through the neck into the mediastinum to the pleural cavity. So perhaps everything was drained out through the pleural cavity, and that was the path of least resistance. And this worked very well. So I take it that your esophagostomy wasn't really a loop that you exteriorized, because that would have, then he wouldn't have been able to swallow. Everything would come right out into the bag. So you just had sort of the side wall of that repair, the side wall of the esophagus just sewn up to the skin, and then there was still a straight shot from the hypopharynx down into the stomach, I gather. And then did you have to go do another operation to close the esophagostomy, or you hope that it'll close by itself?
We hope that this will close by itself. This is already been closed. The patient is eating and the food is going through the stomach. There's just a little bit of, yes, we will wait.
Right. Okay. Yeah, no salivary leak. And you know, in this case, a couple of things. So as Dr. Ramos mentioned, you know, it depends on your facility, that what's easier and how things work. So I understand why you went straight to CT. Probably would have done the same thing in that setting as well. And especially if the ultrasound didn't work and you couldn't tell the stethoscope and he was looking good, you know, just see with the CT. That makes total sense. I think that's fine. And you gave it some thought. And then also in this case, when you did have the thoracic surgeon who did the second operation, it really is up to him. And, you know, because the patient was looking well, you know, if it was a bad decision, you know, and the patient were doing poorly, okay, you would have been more insistent and would have urged that the patient go back, and would have gone back. And I think you know, your consultant, your thoracic surgery consultant would have recommended that as well. So, but really very, very nice case. And sometimes these shots in Brazil, well, if you're going to get shot in the neck, that's the place to go. Last week and this week, you know, they're very good shots. They managed to miss anything that's because of the sudden death. So, you know, I'm really impressed with your assailants down there. So good.
Dr. Ramos.
This kind of shot happen a lot here, sir.
Dr. Ramos, any comments?
Although we are the biggest trauma hospital in Rio, we do have some difficulties with we don't have ultrasound, we don't have contrast, but we do manage to do some miracles.
Yeah.
Anyone
Well,
else?
if I could just say, results are so good, you can make a good case for them buying you an ultrasound machine. You deserve it for Christmas. Put it under the tree.
Any additional comments? Anyone else? Go
Just
ahead.
one comment. I was the one who saw this patient on Wednesday, and he's great, actually. And there's a minor leak, and he's just with a small gauze covering the esophagostomy. And he wanted me to take the gastrostomy out because it's not being used, but I did have to explain to him that we're going to wait a little bit longer to take it out.
Go ahead, Dr. Barros.
So this is all for today. I would like to thank you, all the doctors, for the comments. For me, it's such a pleasure being here with you and learn a little bit more. And this is all. Thank you for the opportunity again.
Thank you, everyone. The CME code has been shared on the meeting chat. And
Thank you.
we will see everyone next week. Thank you.
Yes. Ms. Osorio,
Yes.
Can I ask about any follow-up on the issue about reporting or linking up the CMEs directly with ACCME?
I have not received a response from our CME office. I will follow up and contact you directly with whatever response I get, okay?
Thank you so much.
You're quite welcome, sir. Goodbye, everybody.
Thank you very much. Bye-bye.
You.